Hello, good evening all. This is our ISA 100 platform. Welcome all of you. Today's case meet 24 uh, by Dr. Eshwaran madam. Is this topic is HNF blocks, recent updates. Madam is a consulting anesthesiologist, freelance practitioner mainly. This is important for all of us and received KOP's Best Paper Award in ISACON 2016. Poster presentation at NYSORA International Dubai 2017. JRC Hall of Fame Award 2017. Eshwaran madam has done PVV for modified radical mastectomy and she did almost 100 cases as a private practitioner. It is a great achievement. Last lab TA block also given by madam with RSB for post-op analysis in LA hernia repair. Felicitated at ISACON 2017 at Maharashtra Nanded. She even conducts her own hands-on live airway workshops and no block workshops. Madam has a Ludhiana faculty TAS for live workshop in 2018. She is also co-author for the pocket book on regional anesthesia techniques published in 2019. Award from Dombivili Brahman Sabha. Dish Garva for the year 2020. Madam, welcome. You have given very valuable time on this evening. I'm from IC Nanded. Welcome on this platform. Please, madam, you can start now.
Thank you so much.
Thank you, madam.
Yeah. Thank you, ISA Nanded. It was ISA Nanded in 2017, where I was felicitated first in Maharashtra state.
Yes, yes.
So a lot of memories with Nanded. We had great dance program also.
Yes, yes.
Yeah. I'll be talking on a very different topic, that is head, face, and neck surgeries under regional anesthesia. We as freelancers, this should be very useful. I'll just present whatever I have done. I may not be able to cover the entire, all the blocks which has been described, but I will make a ardent trial. Thank you, ISA Nanded, and thank you all my surgeons and patients for their trust on me, because of which this is possible. Because regional anesthesia, you need more than 90% patient cooperation and surgeon cooperation also. No disclosures. Image and video credit goes to Google, Internet, and NYSORA. This is a photo and video consent form which every patient signs. Now I'll come to certain surgeries. This thyroid, it's very routine, but this patient had severe COPD and was rejected for general anesthesia in many setups. The radical neck dissection is commonly done under GA. Parotid surgeries, cancer tongue lesions. All these surgeries, the ideal anesthesia technique is general anesthesia with endotracheal intubation, with or without muscle relaxation. Okay. Now, what are the blocks of head, face, and neck? The innervations need for the neck, you have cervical plexus block, that is the deep cervical plexus, and the superficial cervical plexus blocks. The face blocks, face is innervated by trigeminal and its branches. And for the scalp, you have the scalp blocks, which covers the trigeminal plus the posterior branch of the cervical plexus. Now, what is cervical plexus? It's very complicated. You read how many times, but I'll try to simplify this. The cervical plexus is a conglomeration of cervical nerves formed by the anterior, that is a ventral rami of the spinal nerves from C1 to C4 roots. The fifth one gives out a part to motor branch to the phrenic nerve. Okay, so this is very important because phrenic supplies the diaphragm. The cervical plexus is defined as a network of nerves formed by the anterior rami of the spinal nerve C1 to C5 that gives off both the motor and the sensory branches. Motor is the deep one, which gives the muscular branches to your sternocleidomastoid, the prevertebral and the levator anine scapula, levator scapulae, the hypoglossal area and cervicalis, the hypoglossal nerves, and nerves to the geniohyoid and the thyrohyoid muscle. And the superficial branches, they come out behind the sternocleidomastoid muscle and branches into the mnemonic is glassed. Okay, that is the greater auricular nerve. G, that is greater auricular. L is your lesser occipital nerve, accessory nerve, and the transverse cervical nerve and supraclavicular nerve. Okay, this supplying, okay, from the outer part of the pinnae mastoid process along the jaw, lower end of the jaw, the midline to your clavicular area up to the shoulder. So it also is the indication. So for the surgery, what all surgeries you can do is anything in this area, okay? That is lymph node dissections, the excision of thyroglossal cyst, your brachial clefts, the vascular access surgeries, your carotid endarterectomies, IJV cannulation, mastoid surgeries, radical neck dissections. Okay, now this is a transverse section of the neck showing how deep your needle should go for each block. Just the superficial cervical plexus blocking the superficial nerves is just beneath the behind the belly of the sternocleidomastoid. No, you're not piercing, just subskin and subcute. You pierce the investing fascia of the neck, you give the intermediate cervical plexus block. But for the deep cervical plexus block, you have to pierce the deep fascia, cervical fascia of the neck. Okay, entering, hitting the transverse process, you enter the deep cervical plexus, fascia to reach the cervical nerve roots here. Okay, so that deep you have to go for the deep cervical plexus. Now I'll come to the superficial cervical plexus. This innervates the skin on the anterolateral part of your neck. The terminal branches emerge from the midpoint of the posterior border of the sternocleidomastoid. Okay. So now what are the landmarks for this? Both the sides, you can see that the needle is shown in a fan shape. You have to inject in all the directions to block all the nerves. Now you have to keep in mind, see this transverse cervical nerve is along the thyroid. Okay, for the thyroid, the greater auricular goes here and supplies along the lower part of your ear lobule, pinna, and anteriorly for some part, the lesser occipital behind the pinna at the mastoid area, and supraclavicular nerves are along the supraclavicular area. Okay, so you have to understand what kind of surgery, and accordingly you have to move the needle, but in all directions you have to give the injection. Now this is an anatomical landmark. Draw a line along the posterior border of the sternocleidomastoid muscle from the mastoid to the clavicular head. Okay, and take the midpoint. Okay, you have to note that the EJV is crossing here. Okay, so the sternocleidomastoid. So you have to avoid the injection into the vasculars. That's the vein. So just take a bit above that corresponding to the midpoint, and you can inject in all the directions here. Just beneath the skin subcute. Do not go beyond the belly. That will be your intermediate cervical plexus. Okay. Now I'll show a video. This is an injection video for the superficial cervical plexus. The needle is bent. You take a simple 10 cc syringe with a hypodermic needle, 23 or 24 gauge. See, I'm feeling from the mastoid to the clavicular end. A line is drawn. This is the midpoint. Just go beneath the skin subcute behind the posterior border of the belly of the sternocleidomastoid. Hardly 0.5 centimeters. I'm bending the needle. See, along the posterior border, you infiltrate in all the directions. That takes care of your superficial cervical plexus. Hardly 5 ml of LA is needed for this. Now, this is the intermediate cervical plexus. You can see the investing layer of the investing fascia of the neck, the pop distinctly. Now you come to the deep cervical plexus. The needle has to go deeper for the deep cervical to pierce the deep cervical fascia to deposit the drug at the root levels, okay, where the spinal nerves emerge out from the intervertebral foramen. Now this can also be termed as the cervical paravertebral block, but as a lateral approach, as opposed to what the posterior approach where you in the thoracic paravertebral blocks you give. Now here the landmarks include the mastoid process, the caudal portion of the mastoid process, the Chasnack tubercle at C6 vertebrae, the transverse process here, and the posterior border of the sternocleidomastoid, that's the clavicular head. Okay. Now what you do is the cricoid cartilage is identified. It corresponds to your T6 transverse process. It's marked here. Okay. And from here, draw a line to from the C6 to the mastoid process. Now this line at intervals of 2 centimeters, 4 centimeters and 6 centimeters you mark, that is the C2, 3, 4, okay, and then C5. That corresponds to the respective transverse process. Just a single injection at C3 level is enough to give a successful, reliable block. Okay. The block needle here, you have to remember that it's very deep and very vertebral artery, or you can puncture the dural cuff to enter the spinal cord at that level. So it's very dangerous. It should be connected to a block needle should be connected to a syringe with LA or a flexible tubing, like in the PNS needle you can take. Okay. Now this is the landmarks, and you keep your finger in between the two transverse process and insert the needle between two palpating fingers and advance the needle perpendicular to the skin. Okay. Never direct the skin cephalad. It can go into the cervical spinal cord. Advance slowly till the transverse process is hit before advancing further. At this point, the needle is withdrawn 1 to 2 millimeters. Stabilize the needle, aspirate for blood, and then inject 4 ml of LA. The needle is removed. The procedure is repeated at consequent levels above and below. Okay. Depth. The transverse process is contracted at 1 to 2 centimeters in almost all the patients. Never go beyond 2.5 centimeters. Searching for the transverse process, you risk the injury of spinal cord. Paresthesia sometimes may be elicited, but it is unreliable. So do not think you are hit. The transverse process is the most reliable landmark. Now, the main indication for deep cervical plexus block has been first described as a carotid endarterectomy. But the contraindications include, since the bilateral block, the block ensues with the ipsilateral phrenic nerve block. Okay, so it is contraindicated in significant pulmonary diseases where the diaphragm gets paralyzed and patient can become serious. And if the patient has contralateral phrenic nerve palsy, there you cannot give, and it's a high risk deep block with potential complications. So you should be prepared for to take care of the complications. Now, knowing the complications of deep cervical plexus block as compared to superficial cervical plexus, the branches, superficial branches, the supply to the anterolateral part of your neck is the same in both the deep and the superficial. So taking care of that, and in superficial, you're not going very deep to block the phrenic nerve. So superficial can be given bilateral. Hence, I tried thyroid surgeries under bilateral superficial plexus block, and this is my paper which was published in 2021. So how I gave bilateral superficial plexus block for thyroid surgeries. The needle is bent here, so you can feel the belly of the sternocleidomastoid along the posterior border of the sternocleidomastoid at the midpoint. In fan-shaped erections, the superficial cervical plexus is blocked. This is a distinct pop of investing layer of the cervical plexus. There again, you give 5 ml of LA. The other side also similarly is blocked. That's the posterior. You can see the external jugular vein, which is avoided. Again, after 5 ml at the superficial cervical, you can enter with a pop of the investing cervical fascia to give the intermediate cervical plexus. This along the sternal notch, you give around 5 ml of LA to block the crossing fibers. Okay, this is an intraoperative video where the patient was asked to deglute and tell her name, and she could answer very well. And the recurrent laryngeal nerve injury was ruled out intraoperative only. You can see that the trachea is nicely bed and the dissection is complete. This was a post-operative video of the patient under trial. She was given sedation score 1 to 2 Ramsay score so that she can answer all our questions intraoperatively also. What are the lessons? What I learned was that vigilant anesthesia monitoring is required. You have to use a screen so that you can always see the patient, and patient's face is easily accessible to you. The surgeon should be cooperative and must contend with slight movements of deglutition and patient movements, and he cannot put pressure on trachea. So he has to lift up the tissue and operate, and the peanuts when they use on the tracheoesophageal groove cannot be done because that causes pressure on trachea and patient starts coughing. Soft, the main complaint of the patient was about the shoulder bolster, which was very hard. So you have to use soft and pliant shoulder bolsters, and claustrophobic patients will not allow. So you have to think and counsel the patient, and it's contraindicated in cases of retrosternal extension. And taking this further, the same bilateral superficial cervical plexus block was used in an unfit patient of 88-year-old COPD who came for bilateral radical neck dissections, where bilateral superficial cervical plexus was given. You can see those huge lymph nodes. Okay, post-operatively, you can see this patient so cooperative. The patient, the surgeon is still suturing, and she is wide awake. Now coming to the innervation of head, face, and neck. Okay. It's mainly innervated by the sensory innervation by the trigeminal nerves. Okay. trigeminal nerves, that is the fifth cranial nerve. The neck nerves, I have superficial cervical plexus, I have already explained. From the posterior ganglionic fibers of the trigeminal nerves, three nerves are formed, that is the ophthalmic V1, the maxillary V2, and mandibular V3. Okay, the ophthalmic is purely sensory. This is purely sensory. Okay, before exiting from the orbit, the supraorbital foramen, it innervates the forehead, the eyebrows, the anterior nasal area, and the upper eyelids. The maxillary, that is V2, is again purely sensory. Via the infraorbital foramen, it comes out and supplies the lower eyelid, okay, the lateral nose, the nasal septum, the cheek, the roof of the mouth, bone, teeth, and sinus of maxilla, soft and the hard palates. The mandibular, that is the V3, this is the V3 area, is mixed sensory and motor, supplying the masticating muscles and sensory in front of the ear, the temporal area, anterior two-third of the tongue, okay, and the skin, mucosa, teeth, and bone of the mandible. The posterior divisions of the cervical nerves, okay, posterior divisions supply the posterior part of the head via the greater and the lesser occipital nerves. The terminal sensory branches of the trigeminal nerve exit the facial bone from the supraorbital foramen, the infraorbital foramen, and the mental foramen, which are at the intersection with the vertical line, passing over the ipsilateral centered pupil of the eye. Okay, so you can feel for the supraorbital foramen for the supratrochlear and the supraorbital nerve, infraorbital foramen for the infraorbital nerve, and mental foramen for the mental nerve. So this is the supraorbital and the supratrochlear nerve. This is the infraorbital nerve. This is the mental nerve showing the sensory area. Now coming to the maxillary nerve. This block is used as an adjunct to GA for major cancer surgeries of maxilla, ethmoidal sinus, pterygomaxillary, or infratemporal fossa. The suprazygomatic approach seems to be the safest and easily reproducible. Okay, the patient is in supine position, head in neutral position, needle entry here. See, this is the maxillary nerve. Okay, you are going the suprazygomatic. This is the zygomatic arch. That's this here. Okay, the needle entry point is found at an angle. This is the angle here. Okay, formed by the superior edge of the zygomatic arch and the posterior border of the orbital rim in the forward. So this is the angle. Use 23 gauge hypodermic needle direct perpendicular advance to reach the greater wing of the sphenoid at a depth of approximately 1 to 1.5 centimeters. The needle is reoriented in a caudal direction, that is posterior, to reach the pterygopalatine fossa around 3 to 4 centimeter depth. Aspirate for blood, and around 0.1 ml per kg up to maximum 5 ml can be given slowly, because these are all highly vascular areas, so you have to be very careful. So you can use PNS, which is we can locate the pterygopalatine fossa. Now coming to the mandibular nerve, it is blocked where it emerges from the foramen ovale, comes out of the foramen ovale here, bounded by the zygomatic arch at the top and the mandibular notch here. Okay, here you can see the zygomatic arch and the mandibular notch just anterior and below the tragus of the ear. The needle entry point is located between the coronoid process and the coronoid notch. Okay, here. This is the anterior and the posterior border of your mandible. You can ask the patient to open the mouth and close and keep a finger in front of your tragus. You can see the notch you can be felt very easily. The depth of the needle should be just around 2 to 2.4 centimeters. You can use just 5 ml LA and your routine 23 or 24 gauge hypodermic needle. A perpendicular penetration to the skin is needed. You can advance it further if you use a spinal needle to reach the pterygoid plate at around approximately around 4 to 5 centimeters. You should hit the pterygoid plate. Okay, this is used for trigeminal neuralgia. If you use a PNS, this is a PNS guided mandibular block. You can see that around a 5 centimeter needle, hardly 1 to 1.5 centimeter, you get the contraction of the mandible. Okay, the LA dose is around 0.1 ml per kg. Maximum you can give is 5 ml of LA after negative aspiration. Now, what are the nerves blocked? And the area. Okay, the ipsilateral mandibular teeth, the buccal and the lingual and hard and soft tissues, anterior 2/3 of the tongue and floor of the mouth. So this can be used for, this was used for parotidectomy. Now this was a patient of with cardiac disease. Now innervation of parotid also I will explain before I go to the video. The pinna of the ear. The pinna of the ear is innervated by the trigeminal nerve and the cervical plexus. The superior 2/3 of the anterior surface by the auriculotemporal nerve of the mandibular division. Okay, that is the trigeminal. And then enter this same auriculotemporal, enter the parotid to supply the parotid gland. Okay, then the posterior surface of the ear pinna, here it is supplied by the lesser occipital, greater auricular and the lesser occipital. The greater auricular then supplies the fascia over the parotid gland. So what all nerves you have to block is auriculotemporal, lesser occipital and greater auricular. Lesser occipital and greater auricular is blocked at the cervical plexus block and auriculotemporal at the mandibular nerve block. So what I gave in this patient for parotidectomy, which had global hypokinesia, 5 ml at the auriculotemporal, greater auricular was covered at the superficial cervical plexus, 5 ml. And for the incision, the mandibular block was given 3 to 5 ml. LA mixture, which was used, was 2% adrenaline xylocaine 10 ml with 0.75% ropivacaine 10 ml. 3 ml added at zygomaticotemporal nerve block, just because if the incision was extended above. So this is again the same similar video where the superficial cervical plexus block was given. Every time I bend the needle so that the deeper inadvertent vascular structure at the deeper level is avoided. That's the superficial cervical plexus. Okay, in all the directions, especially the greater auricular and the lesser occipital area. Post-operative, you can see the video. The patient is, she is showing the teeth. The facial nerve injury is ruled out. Okay. Now again, a patient of CA tongue with radical neck dissection had come. This patient was 92-year-old, mother of a doctor, hypertensive, diabetes mellitus, and age-related ECG changes. You can see the tongue lesion here. The radical neck dissection was done. This patient was given a glossopharyngeal nerve block at the tonsillar pillar base 3 ml and midline tongue at 3 ml was given. You can give mandibular nerve block also. Superficial cervical plexus was given 6 ml and intermediate cervical plexus block 5 ml. LA mixture used was a combination 10 ml of 2% adrenaline xylocaine and 10 ml of 0.75% ropivacaine. Sedation of 1 milligram midazolam and just 1 gram of paracetamol was given. Okay. Again, this is a repeat of the superficial cervical plexus block. You can see the external jugular vein. This was 92-year-old. You can see the skin so friable. You can see nice veil being raised. You can see the drug spreading in all the directions. Okay, and this was the intermediate cervical plexus. Okay, can clearly see the. Now, why did I give the glossopharyngeal nerve block? This is the innervation of the tongue. Anteriorly, it was from the trigeminal, the mandibular nerve block will take care of the anterior supply. But the posteriorly, you needed, because repeatedly when the tongue was being pulled, there was gag reflex. The glossopharyngeal nerve block on the ipsilateral side takes care of the gag reflex. I did only one side so that the deglutition is preserved. Swallowing reflex is preserved. So the ipsilateral glossopharyngeal nerve block was given. This is the intraoral approach. Okay, for at the base of the anterior tonsillar pillar. This is the tongue depressor seen. This is the tongue posterior part, and this is the needle entry point at the anterior tonsillar pillar. This was a CO2 laser was used. You can see absolutely not a single drop of blood was allowed to enter. There is no bleeding at all, and the patient was easily cooperative. Post-operatively, you can see this patient being responsive and talking well. Now, the same thing I had managed to publish a case report with very much difficulty. Lot of questions I had to answer, but finally I could publish this as a case report. Now, superficial cervical plexus block was also used for tracheostomy. No? In a patient for CA larynx, you can see this was a lesion. Later on, after tracheostomy and securing the airway, I gave GA, okay, for the laryngectomy. Now, thyroid, this was a patient of thyroid with cranial metastasis. Okay, so here, see the picture, the cranium was metastasis, metastatic lesion was piercing and coming out. This was the thyroid lesion. This patient also had convulsions with cranial mets. There was lung mets, spinal mets. Patient had undergone radiotherapy. The coagulation profile was normal. Therefore, the superficial cervical plexus block with scalp block using a mixture of 10 ml of 2% adrenaline xylocaine and 0.75% ropivacaine was given. I could not give any sedation to this patient. 1 gram paracetamol and 20 mics of dextromid throughout the surgery was given. Now coming to scalp block. This innervations have already explained. The 7 nerves supplying the scalp blocks are the supraorbital nerve, the supratrochlear nerve. Both these are given at single injection. The zygomaticotemporal nerve at the lateral part of your canthus, eye canthus. Okay, the auriculotemporal nerve in front of your tragus. You have to be careful about the auriculotemporal artery. You can palpate it to avoid inadvertent arterial puncture. And posteriorly, you have the lesser occipital and the greater occipital. Now, how do you, the landmarks is that you take the occipital tuberosity and the mastoid, draw a straight line, divide it into three different equal parts. The junction between the lateral one-third, lateral one-third and the medial two-third is your lesser occipital, and the medial two-third, medial one-third and the lateral two-third is your greater occipital. Greater occipital nerve as adjacent to it is the greater occipital artery. So you have to be careful of the arterial puncture. Now this is the skull block video. See, I'm feeling for the supraorbital foramen. These two are the supraorbital, and the supratrochlear nerve is covered by a single injection of 3 ml of the LA solution. Okay. Then at the lateral outermost canthus is your zygomatico-temporal nerve. These are all superficial nerves. You raise a nice wheel to cover it. This is your auriculotemporal nerve. You have to aspirate to rule out the blood vessel, that is the auriculotemporal artery. Now you divide this line from the mastoid process to the occipital tuberosity into 3 different parts. This is your greater occipital at the medial one-third to the lateral two-third junction, and the lateral two-third to the medial, lateral one-third to the medial two-third is your lesser occipital. And to cover the anterior and posterior to the ear pinnae, you have to give the superficial cervical plexus again here in to complete the scalp block. Now, if your lesion involves, this was a skin CA, you can see this lesion, they were to do a flap surgery. So it might go or cross the midline. So I gave the opposite side supratrochlear and the supraorbital nerve also. So this was the flap raised. For awake craniotomies also, where you need to map the motor area, you can give scalp block and do the surgery with the patient awake. Here you can see this is an intraoperative video where the patient is asked to move the limbs, fingers. So the patient is moving the fingers while the surgery is going on in the motor area. The patient can make a fist and help the surgeon map the tumor area. Okay. So the patient was given sedation, but kept the sedation score to Ramsay 1 and 2. Now, there are many articles showing that the scalp nerve block being better than the scalp infiltration in terms of intraoperative hemodynamic and stress responses, and thereby the intracranial pressures and postoperative inflammatory response and pain control was better. Okay. Now, what are the clinical pearls in the scalp block was the hypotension has been reported. So you have to be very careful. Keep aspirating for CSF, especially if patient has a fracture skull also along with it. You have to be very careful. Inadvertent subarachnoid space injection in fracture skull and occipital nerve blocks, you have to beware of that. Inadvertent arterial injection, retrograde carotid, internal carotid artery and cerebral circulation can occur. Facial nerve paralysis because of proximity to the facial nerve has also been reported. Now, RA as an adjunct to GA. Now, this was a patient for commando surgery with PMMC flap who had a LBBB and with an LVEF of 30%. In the PAC, the patient was explained induction was done along with etomidate, sevoflurane, nerve blocks. What all I gave was mandibular, superficial cervical plexus block, and also thoracic paravertebral block. Okay, so that my GA drugs are very minimal. This way, the GA was required only for tolerating the endotracheal tube, and patient had excellent postoperative pain relief. Patient was extubated after 4 hours. So thoracic paravertebral block using PNS, and then the patient was made supine, mandibular nerve block, and a superficial cervical plexus block was given. This was the intraoperative picture and post-operative picture. Now coming to the other blocks, that is the sphenopalatine ganglion block. It arises from V2, that is the maxillary nerve. It's used in treating migraine, headaches, facial pain, syndromes, endoscopic surgery pain for post-op pain relief and intra-op pain relief also. It has also been used to, this is a sphenopalatine ganglion, used to treat the anterior headaches after post-dural puncture headaches. Okay, so how this is a transnasal approach, a cotton swab or a syringe with 25 gauge needle can be used. It's dipped in LA. This is the anterior ethmoidal nerve block with the cotton swab, and here you block the sphenopalatine ganglion. You keep the cotton swab dipped in LA for some time, and you can repeat for PDPH. This works excellently. It's a trans-oral approach also. You can use it at the groove between the first and the second upper molar tooth. Okay, you can keep the cotton bud soaked with LA. 4% xylocaine gives better results. Keep it for some time till the pain relief occurs, and patient later on keeps it themselves. Now I cannot complete the HFN blocks without speaking about airway blocks. The superior laryngeal nerve and the recurrent laryngeal nerve are the branches of vagus nerve innervating the larynx. The superior laryngeal nerve is blocked as it passes inferiorly to the greater cornu of the hyoid bone. You can see that here. Okay, it splits into the internal and external branches here. And the recurrent laryngeal nerve block is blocked by a transtracheal injection of LA at the cricothyroid membrane level. Okay, after aspirating, you give 5 ml of LA. Okay, you get a distinct pop of the cricothyroid membrane. See, this is how you feel for the greater cornu, and at the inferior to the greater cornual of the hyoid bone, you inject for the superior laryngeal nerve block, and this is the transtracheal injection for your recurrent laryngeal nerve block. Okay, now for all these head face neck blocks, you have to keep all the resuscitative equipments always ready. Monitors should be attached while performing the blocks. Proper informed consent should be taken. Vigilant monitoring and communication should be throughout the surgery. GA is always first choice and should be ready. It's not an alternative for difficult intubation. Surgeon should be explained and he should be content with minimal movements. The muscle twitches, muscles are not paralyzed. The cautery can lead to muscle twitches. The dissection should be after the lift up technique rather than push up over the neck by peanuts. Separate and powerful suction. The OT should have 2 suctions, one for the anesthetist and one for the surgeon. Claustrophobic patients can be difficult. The Ramsay sedation score of 1 or 2, where the patient can talk to you and communicate with you. It's contraindicated in cases where heavy bleeding is expected, difficult airway, and surgery is of very much prolonged duration. And last but not the least, intralipid should be available. The LA toxicity is more reported with not with higher doses, but more with little dose going intravascular. And HFN is highly vascular and very much big vessels are present. So without intralipid and without resuscitative equipments, you cannot proceed. Thank you so much. I say Nandit. Thank you. Hello. Hello.
Only mutton. Hello.
Hello.
I'm superb talk. Any question and answer if have, we'll check in question box.
Yeah. I hope I covered all the points.
Yes, ma'am. You covered almost everything. I think no questions from audience. It's our silver jubilee year with national platinum jubilee year. So I started this case meets for every weekly. And
Yeah, it's a great thing. Something is going on then.
yes, ma'am. And lot of speakers we are learning from them, and especially about you. You are a private forum person.
Yeah.
You do practice in private forums, and you know the difficulties and other
Yeah.
problems.
And we have to be, people think private practitioners do not take care, no?
Yes, ma'am.
It's not that. If you consider we have to juggle work as multitasking, so these blocks really help us in reducing the GA doses. If at all you're not doing under sole regional technique, these are very easy blocks which people are not using. No, for example, if you give a mandibular block for a Quincy patient, or mouth opening was nil, or a fracture mandible patient, if you give a mandibular nerve block before giving GA, you can see drastically, you can see the patient is able to open mouth, and your fear of difficult intubation is reduced. No? So one should try out.
So overall, you did a lot of regionals in HNF, and you work on that superficial cervical block. One of the master things you achieve.
Yeah, I started using it on all any HFN cases you can put it in, and 5 ml of drug, so much safe it is. It's not at all very risky. Even if you go intermediate cervical, it's very easy and it's safe.
Yes.
That's what I want to say. You should start using it. You don't need a sonography machine also.
Still, without sono guided blocks, means in our area in private forums, it's difficult to carry on sono machines in OT, or even that luxury we don't have. Still, you're doing on
even if we have now, we do not have time.
Yes.
To start somebody has to know you. We do not have personnel to get it in the OT, start it, boot it. So we are always in a hurry. A private practitioner running from hospital to hospital, it's very difficult. And so many questions are asked. Anything else? Any more questions? Shall we end the seminar?
I'm in OT basically. That's why I'm muting myself for a while.
Yeah.
Uh, yes, ma'am. It's our very what I can say is a great thing that you came on our platform, and really happy on these weekends that you gave us a valuable time, and congratulations for your son also, that exam is in next week something, no, ma'am?
Yeah, part one is over, and he'll be giving there are
From
5-6
ISA Nanded, we all give best luck and
Thank you so
congratulations for
much.
future.
Yeah.
Yes, ma'am.
And
So for this evening, yes, ma'am. Thank you from our ISA Secretary Nanded and
I
our
hope
President Dr.
people
Kutkar sir
can,
also.
I mean, people practice this blocks.
Yes, yes,
It is
ma'am. This will
rarely
be
done.
uploaded on YouTube also in
Yeah.
2 to 3 days when this recording is available with us. And I will share this recording with you also.
Thank you. Thank you so
Thank
much.
you.
Yeah.
Thanks.
Yeah.